Dear colleagues, ladies and gentlemen, after all this theoretical part of carrying out meta-analysis, I'd like to show you an example that it is not an impossible task. 2 years ago, I would not believe that I will be able to do meta-analysis and that meta-analysis will even be accepted for publication in a highly ranked journal. By showing these meta-analysis, I would like to give you some practical points about the preparation of this type of manuscripts. So our first meta-analysis with my PhD student Daniel Pécsi, that was the first for him, first for me. We chose a topic about the difficult cannulation, difficult biliary access during the ERCP procedures. And this meta-analysis was started in 2016, somewhere in May, June. And we finished the manuscript in October, November. First, it was submitted to the gastrointestinal endoscopy. They gave out the paper for reviewers. From the reviewers, they didn't accept it for publication, but from the reviewers' comment, we could use a lot of good points to further improve our manuscript, which took us another 1 month or 1.5 months to improve it, and sent out to the endoscopy in January 2017. It came back 2 months later with the major revision, and after that we could complete the major revision, and it was accepted for publication. The title, you heard a lot about the title, that the title should be as specific as it is possible, and the title, just by reading the title, you will know what's about all these papers. So we gave the title of Transpancreatic Sphincterotomy has a higher cannulation success rate than needle knife bracket papillotomy. This paper also got an editorial on the same issue, and it was put on the cover page of the endoscopy journal. And in this editorial, we could have read that it is an elegant meta-analysis comparing the success of and complication rates of different cannulation methods. And by reviewing these data, which were presented in the meta-analysis, the editor became convinced that this procedure might be more successful with lower incidence of complications. But obviously, the editor has some worries about these methods. Namely, we cannot know much about the late-term consequences of this type of procedure. Anyhow, let's see what is the clinical problem, whether it is a relevant clinical problem or not. During the ERCP procedure, we have these clinical scenario quite often. 10 to 20% of the cases, which those patients who did not have this procedure before and had a naive papilla, we might face it quite frequently. What is the definition? That was one problem with the meta-analysis, that the definition is not really existing, or it is actually formulated in the recent guidelines by the European Society of Gastrointestinal Endoscopy. Without showing too much details, you can read it from the slide. Let's go further, and just to quickly show you what a guideline is saying, which was appeared after we started our search for the meta-analysis. And when this guideline was published, we became quite uncertain whether it is worth to proceed with our research, since we have a guideline which clearly states what should we do in cases of different cannulations. And the transpancreatic biliary sphincterotomy is only the last resort according to the guideline. But let's look at a bit more closely what these guidelines say and what type of evidence do we have for or against this type of methodology that we are investigating. It says that there are no real good data to guide the endoscopist when selective between the transpancreatic sphincterotomy and other pre-cutting method when we are facing with difficult cannulation. And also in the meantime, while we were preparing our meta-analysis and doing the data analysis, another meta-analysis appeared about the usefulness of another methodology which is also recommended in cases of difficult cannulation, and turns out that this double guide wire methodology is not really a safe procedure because it is increasing the risk of one of the most frequent complications of ERCP. So the guidance is also a strong recommendation, but with a relatively moderate quality of evidence. So it means that we still might have a place to analyze data and to start this type of work or continue exactly this type of work. So what was the method of the meta-analysis? We used the PICO format, what you heard recently. Our population were the patients with difficult biliary cannulation during ERCP procedure, whatever was the indication for the ERCP. The intervention was transpancreatic sphincterotomy. The comparison was another more frequently used method, namely the needle knife pre-cut papillotomy method, and we wanted to compare the outcome. We wanted to compare the success rate, the complication rate of these two procedures. So we did a systematic literature search. As you heard previously, we used 3 different databases, the Embase, the PubMed, and the Cochrane. And also we did this search many times, and the latest search was on 9th of December 2016, so just a few weeks after finishing the manuscript. We also applied the PRISMA guidelines, what you recently heard from Peter Verju, and we selected all articles which compared the transpancreatic sphincterotomy with the needle knife papillotomy. We selected not only the randomized prospective trials, because these were relatively few, also selected non-randomized and retrospective series without any further restrictions. And also we had to face with the problem with using different synonyms which are basically meaning the same type of procedure, same type of terminology. So this is just an example that how many different search phrases should have been put into the search. And by carrying out this literature search, we finally after removing duplicates, after checking the articles, 13 studies were included in the meta-analysis, and out of these 13 studies, 5 studies were prospective studies, and the rest of the studies were retrospective. So we also had to do the quality assessment of the included studies. The JADAT score was mentioned in the previous lectures. We used that only for 2 studies, which were prospective randomized studies, and all the other studies were evaluated by another scoring system, which was not mentioned now, the minors score system. And you have to give points according to this scaling system. At least 2 of the reviewers have to assess these independently, and we have to reach a consensus after finalizing this type of table. But it is also appearing in the accepted accepted article. What statistical methods we were using? We mostly used pooled odds ratios and confidence intervals, but after the review, one of the reviewer criticized this type of methodology. Namely, he said that the odds ratio might overestimate the effect size, and they also wanted us to evaluate the relative risk ratio, and turned out that the odds ratio and the relative risk ratios were closely the same, and the same level of significance was reached. So I think that is also could help to accept the final form of the manuscript. Also, in some parameters, when we have a very low number of complications, namely perforations, risk difference should be calculated, because otherwise, we had to exclude a lot of data. And also, we have to evaluate the data sets, whether it is a homogeneous data set or heterogeneous data sets, and different effect models can be used. Heterogeneity tests should be also carried out, and publication bias, as it was mentioned previously. So what are the results? Just very, very quickly, that was the first main result, the cannulation success, showing that we have an odds ratio of 0.5, meaning favoring the transpancreatic sphincterotomy, and also in the supplementary material, the funnel plot analysis was published. The problem with these, since it is containing a lot of retrospective data, that the data are very heterogeneous, as it is seen by this Q and I square statistics. It is a highly heterogeneous data, which makes the evidence low level of evidence. So what can we do with this type of problem? We can select only the prospective data to see whether the results are remaining or showing similar tendency, and it was the case. It got even higher level of significance. And what happened with the Q and the I-square values, we can see that now we have a very low heterogeneity of data sets, which makes the conclusion a stronger conclusion. All the other parameters, like the post-ERCP pancreatitis rate, was evaluated. There was no significance, even if we are selecting or subdividing the studies according to the prospectivity of the study. So it came out with a moderate heterogeneity without any effect or neither of the procedure. And another major complication of this type of cannulation methods or papillotomy methods is the post-papillotomy bleeding, and actually it showed some benefit of the transpancreatic sphincterotomy, which is rarely used and much commonly used the other way around, other way of the difficult cannulation. But again, the heterogeneity is low, but the funnel plot, you can see an asymmetry. So these also make the conclusion, this type of conclusion or this part of the conclusion, weaker, since we don't have a good symmetry when we are doing the funnel plot. All these limitations, what I partially mentioned, should be discussed in details in the discussion part. The heterogeneity, since the lack of common definition of what was mentioned as difficult cannulation, the definition of it was relatively heterogeneous, and because of the low number of available randomized trials, it can cause a significant heterogeneity. We could partially decrease the heterogeneity by selecting only or separately analyze the prospective studies. Heterogeneous definition of different complications was also a concern, and the other major concern that currently the current guidelines are recommending certain type of prophylactic measures to prevent one of the most feared complications, the post-ERCP pancreatitis occurrence, and these were not applied universally, or a lot of studies did not apply this type of prevention. So after evaluating all these limitations and all the results, what can we say in the conclusion and in the recommendation? That this transpancreatic sphincterotomy can increase the rate of biliary access compared to another more commonly used method, namely the needle knife Praecut papillotomy in patients with difficult cannulation without causing more pancreatitis, and even we have a decreased frequency of bleeding. And also, what can it influence? compared to the current guidelines, that the suggested algorithm might be an earlier application of this transpancreatic sphincterotomy compared to the current guideline. And obviously, since we have a relatively low level of evidence because of the heterogeneous data and the low number of prospective randomized trials, obviously we need further prospective multi-center studies, and that is also in the conclusion of the accepted article. And after a few months later, really another study, it's also a monocentric study with a relatively low number of patients, investigated this type of cannulation and said, which was very similar to our meta-analysis data, that this transpancreatic sphincterotomy is more successful than other methods which are suggested first by the ESG guidelines. If biliary cannulation cannot be achieved, these authors are also saying that the transpancreatic sphincterotomy can be applied earlier. Thank you for your attention. That was the story of my first meta-analysis, and I'd like to encourage all of you that it is not an impossible task. It is a long way, and we learned a lot along the way, but it is doable and learnable. Thank you very much.